Hi everyone. Today's lecture is on heart failure. Heart failure is a very complex disorder that can be chronic or acute. The symptoms can range from mild to severe and can even lead to death. In Block 1, we are focusing on chronic heart failure. You will focus on acute and severe heart failure later in Block 4. Our lecture on heart failure will focus on the pathophysiology of heart failure, assessment findings in patients with heart failure, diagnostic criteria for heart failure, and the treatment of heart failure. I said heart failure is a very complex disorder, and it's not uncommon for patients to present with different symptoms. It's also not uncommon for different treatments to work for some and not for others. Before we get into the pathophysiology of heart failure, we need to discuss some cardiac terms you need to know. Preload is a common cardiac term you will hear in the treatment of heart failure. You will hear nurses and providers say we need to reduce preload. So what exactly is preload? Preload is defined as the amount of blood returned to the heart, specifically the amount of blood returned to the ventricles. Many times, preload is just used to describe the amount of blood returning to the right ventricle from the periphery. In Block 4, you will learn about preload specific to the left ventricle from the pulmonary blood supply. The reason preload is so important is your heart is like a big balloon. The more we fill the balloon with air, the more it stretches. But if we fill our balloon too much, it pops. Our heart doesn't pop, thankfully, but when it stretches too much, it gets weaker and cannot contract as well. I highly suggest you refresh yourself on Frank Starling's law from way back in Anatomy and Physiology. Afterload is another common cardiac term you will hear. Afterload is the amount of peripheral resistance the heart must overcome to get the blood out of the heart and into circulation. I like to think of afterload as the diameter of a tube. If I need to move 100 gallons of water, would I rather move it through a straw or a garden hose? Now imagine that tube is your aorta and your blood vessels. Is it easier to move the blood through wide open, dilated blood vessels or tight, constricted blood vessels? The more constricted the blood vessel, the harder the heart has to squeeze to get the blood out of the heart and into circulation. Here's a cute picture of the heart. On the left side of the picture, we have our preload, which can be increased by hypervolemia or fluid overload and heart valves that are not working correctly. On the right side of the picture, we have our afterload, which can be affected by hypertension and vasoconstriction. We have some more cardiac definitions, two of which you already know, systole and diastole. Systole is the contraction or the squeeze of the heart when blood is ejected out of the heart and into circulation. Diastole is when the heart muscle is at rest and the heart is filling with blood. Both of these phases of the cardiac cycle are important when it comes to heart failure, as we can use treatments to alter them both. Ejection fraction is the amount of blood ejected from the heart with each heartbeat in percentage form. Typically, a normal heart will eject 50 to 70% of the blood in the ventricles with each heartbeat. That means our heart does not eject all the blood out, and that is normal. Knowing a patient's EF is important in heart failure as it tells us how strong the contraction is and how much blood is left over in the ventricles. The more blood left over in the ventricles, the less blood that is going into circulation, which means less oxygen to our tissues. Also, the leftover blood in our ventricles can pool and start to coagulate and form blood clots. This is not an ideal situation for our patients. Another term you need to know is cardiac output. Cardiac output is a number computed from multiplying our stroke volume and our heart rate. Stroke volume is very similar to EF, except it's a volume in milliliters and not a percentage. Normal stroke volume is 60 to 130 mLs per heartbeat. Our stroke volume is affected by three things: preload, afterload, and contractility. We've already discussed preload and afterload, and contractility is the strength of the heart contraction. How strong is our heart beating? Contractility can be affected by preload. The greater the stretch, the greater the contraction. We can use medications and treatments to alter all three of these, increasing or decreasing our cardiac output is needed. Cardiac output is also affected by our heart rate, and we learned in week 2 that our heart rate is affected by a lot of things: fever, exercise, sleep, medications, and many more. We can alter our cardiac output by changing our heart rate. When we slow our heart rate, we allow the heart to have longer diastole, allowing more blood to fill the ventricles. Or we can speed up our heart to lessen the filling time to decrease our cardiac output. Another process that affects cardiac output is our sympathetic nervous system and our parasympathetic nervous system. Our sympathetic nervous system stimulates epinephrine and norepinephrine, our fight or flight response, and increases contractility and heart rate so we can fight off that bear or run away as fast as possible. Our parasympathetic nervous system can be activated to let us rest and digest and slow our heart rate and our contractility. Any of you who are interested in being ICU nurses, this is the reason why ICU nurses exist. We alter cardiac output all day long. All right, let's take a break.